Basal cell carcinoma presented by Kenneth J. Winter. Week 7 narrative PowerPoint presentation, Bio 251, CRN 11123 for Dr. Simmons, MD. Introduction. Basal cell carcinoma, BCC, is the most common type of skin cancer, comprising of 75 to 80% of non-melanoma cases. It originates from basal cells in the epidermis and is primarily caused by collection ultraviolet radiation, particularly UVB, which damages keratinized DNA. Although BCC is slow growing and rarely metastasizes, it can cause significant local damage if untreated. Often occurs in sun exposure areas like the head and neck. Advances in understanding its molecular pathogenesis, particularly in the hedgehog signaling pathway, have led to treated therapies, improving treatment options, and advances for recurring cases. Part 1. Pathway overview is considered to be a major signaling transduction pathway during embryonic development, but it usually shuts down after birth. SHH activation during adulthood to neuroplastic growth. BCC of the skin is driven by this pathway. In BCC, mutations often occur in the genes that regulate the hedgehog pathway. When PTCH1 is mutated, it no longer emits SEMO, leading to uncontrolled activation of the pathway. This deregulation results in excessive activation of glial transportation factor, promoting and expressing of the gene that drives cell proliferation and survival, leading to the formation of tumors. Part 2. Basal cell carcinoma, BCC, is the most common type of skin malignancy. The lifetime risk of the development of skin cancer is estimated to be 1 in 5, with more than 97% being NMSC. The risk for developing subsequent BCC after the initial diagnosis of NMSC is substantial. Patients with one index BCC developed 1, 2, or 3 new BCCs in 33%, 14%, and 7% of cases within 1 year, the time frame in which the highest rate was observed during a 3-year study. Patients with NMSC also have been shown to be at substantial risk for developing melanoma, with a relative risk of 17% compared to general Caucasian population. So here we have a graph. On the side, it has a population of 100,000 going up, and on the bottom, we have the age group throughout the years. As you can tell by the data on the chart, as you get older, your risk of developing skin cancer increases. Part 3. Clinical presentation. The main clinical subtypes of basal cell carcinoma are noder, superficial, and morphiform. Combinations of the latter two with noder BCC may occur. Occasionally, variable amounts of melanin may be presented within the tumor, which are often referred to as pigmented BCC. Most common cases of BCC occur in the face consist with the accumulation role of UV radiation. Clinical variants of basal cell carcinoma are A. Noder, B. Pigmented variant, C. Large noder basal cell carcinoma, D. Ulcerative aggressive basal carcinoma, and E. Superficial basal carcinoma, and F. Recurrent basal cell carcinoma. And on this slide here, we have pictures that show clinical presentation of basal cell carcinoma on patients. Then this other image here is the guide for basal cell carcinoma symptoms. It goes over most common warning signs, which are new skin lesions, itching at the lesion, easily bleeding during shaving, non-healing incisions, and color changes in skin pigments. And then in BCC prevention, you avoid midday sun, use sunscreen, cover up your skin during the sun, and avoid tanning beds. Part 4. Diagnosis. After visually inspecting a lesion in search of characteristic features of BCC, clinicians can rely on dermoscopy to further refine the differential diagnosis. Pigmented BCC can be a diagnosed challenge because they can demonstrate dermoscopic features such as melanocytic lesions, such as multiple to black dots / globes, blue / white veil-like structures, and non-reabsorbing vessels. Biopsy is the only way to finally diagnose BCC and decide an appropriate treatment. The diagnostic accuracy of punch biopsy, defined as the preparation of holistic diagnosis made by punch biopsy that can subsequently confirm after surgical excision of primarily BCC, has been reported in various studies to be 60 to 82% correct only. On this slide, we have two images. One of them is the ABCDE checklist. This is a guideline that helps clinicians help diagnose skin cancer in patients in a hospital. So let's go over this together. A is asymmetry, B is border, C is for color, D is for diameter. It depends on how deep it is in the skin. That helps categorize what kind of skin cancer it is. And E is for evaluation. So this evaluates mole size, diameter, color, just the whole checklist all in one. And then over here on the other side, we have an image of what it would look like inside the skin. So as you see, we have epidermis, dermis, and hypodermis. And as you can tell, the different types of skin cancers reach different types of levels within the skin. So that just tells you the severity. And then on this slide here, we have a video which I think she can do a much better job of explaining it than I can.
And today we're going to do a quick review on how to identify melanoma using the ABCDE assessment. Here we have this lesion on our patient, and we're going to use the ABCDE assessment to see if this may be melanoma. So A, that represents asymmetrical, and to determine this, you would draw a line down the middle of the area and see if it looks the same on each side. If we did that here, it would not look the same on each side. So this area is definitely asymmetrical. Then we would look at the borders, and we're looking to see if they're even or uneven. And here our borders are not nice and round. They are definitely uneven. And then we would look at the color. Here, this color is very suspicious. It's a very dark black color. Also, you would want to be aware if it had multiple colors in it, that would be alarming. And then we would look at the diameter, and anything greater than 6 millimeters is concerning, and this one is definitely greater than 6 millimeters. Then we would look at the evolution. Has it been evolving in its shape, size, or color? And you would want to ask the patient about this. And if it has, this means we are suspicious that this may be melanoma and the patient would need a skin biopsy. Now let's compare that lesion to this lesion. And again, using the ABCDE assessment, we're looking to see if this is asymmetrical. This is not asymmetrical. If we draw a line down the middle, it would look even on each side. It would look the same. The borders are nice and even. They're not uneven like the one we just seen. The color is nice and uniform. We see one color and it's brown. The diameter is not greater than 6 millimeters. It's around 2 millimeters, which is good. And evolution is not present. It hasn't changed in its size, shape, or color. Therefore, we would determine that this is a common mole. And with your patients, you want to teach them to do a monthly skin assessment and to follow this ABCDE acronym. Okay, so that wraps up this review over the ABCDE assessment for melanoma. Thank you so much for watching, and don't forget to subscribe.
Part 5. Histopathology. The BCC histopathic subtypes are classified according to the risk of tumors. BCC with the low risk of reoccurrence are noder, superficial, and pigmented. However, those with high risk of reoccurrence are micronoder infiltrating, morphic, and basal squamic BCC, and BCCs with chromatic differentiation. Then here on this slide, we have the histopathological subtypes, starting from the most cases all the way down to the least. Part 6, management. Management and treatment of basal cell carcinoma, a common type of skin cancer, primarily aimed to remove or destroy the cancerous tissue while minimizing damage to surrounding healthy tissue. The choice of treatment depends on factors like size, location, subtype, and the carcinoma. As the patient's overall health and preferences, here are some common management and treatment options. 1, surgical treatment. 2, non-surgical treatment like topical treatments and radiation therapy. Then for advanced and reoccurring basal cell carcinoma, we have targeted therapies and systematic therapies. And for follow-up and monitoring, BCC has a high reoccurrence rate, so regular skin checkups by the dermatologist are essential for early detection of new basal cell carcinoma growth or reoccurrence. Patients also advised to protect their hair and skin from sun exposure and use sunscreen and wear protective clothing and avoid peak sun hours. On this slide here, we have a video that shows and demonstrates how a surgeon removes a basal cell carcinoma from a patient. And here are all the references that I used for this presentation. Thank you all for watching. I greatly appreciate it. If you have any questions, here's my school email below. Thank you.